Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Kaigenesis, a supplement range we have made for people diagnosed with chronic kidney disease so they don't have to take 50 million nutraceuticals in one go. And I'm joined again today by the amazing, stunning, wonderful Lindsey Zirker. Lindsey is part of the KNI, so Kidney Nutritional Institute team. Lindsey and I were just talking before I hit record. We have been asked, in fact, I haven't said this on any podcast, but a group of us, including Jessiana and some other people that we know in the kidney field, have been asked to contribute to a Springer Nature textbook. And if anyone knows who Springer Nature is, it's the Nature journal, which is very prestigious. And then Springer Nature puts out medical textbooks. So we have all been asked to contribute and write different chapters on kidney disease that will go to nephrologists and doctors and medical students training alike to tell them and support them in how to and educate them in how to treat kidney disease from a broader lens, should we say, and that potentially kidney disease is treatable and what nutraceuticals and dietary interventions and how the hormones work. So Lindsey and I are busy working away on that, giving ourselves a nice hardcore deadline. But Lindsey's amazing brain, she was just telling me how she's got the fabulous chapter of hormones. She's just going through how she's laid it all out, which is going to be brilliant for anyone that has the privilege of reading this textbook. So so that's what Lindsey and I are actually working on. And in our side bit, we go down the rabbit hole of minerals. So we did the zinc discussion last time and then realized we thought we had done magnesium and we realized we hadn't. It's just one that Lindsey and I talk about so much because it's such an important one. So we're circling back to the amazing mineral that is magnesium and its role in kidney disease. So Lindsey, I know how busy you are with writing this chapter for the Springer Nature and the integrative approach to treating chronic kidney disease, I think is the name of the textbook, something like that. Yeah. So thank you for carving out some time to talk to me about probably my favorite mineral of all time, magnesium.
Yes, magnesium is super cool. I should have looked it up ahead of time to see how many reactions. We probably don't know actually how many reactions that enzyme is a cofactor for and the enzymes and stuff like this.
I think, or thereabouts. And you're right, we don't know, but it's around that, I think.
Yeah. So I think one of the reasons we like it so much is because if we think, seems like some biochemical pathways aren't working, then probably magnesium is a really good place to start.
Yeah, I definitely concur with that. And so many people are deficient in it because it's the number one mineral that gets chomped up when you're stressed. So
yes. So yeah, magnesium, it does so many different things. It used to be in kidney disease that everyone was worried that magnesium levels would get too high because the kidney wasn't filtering magnesium out. And so I remember when I first started working in dialysis, just a couple years ago, that everyone was freaked out about it. And they're like, oh, never give anyone on dialysis or with kidney disease, never ever give them magnesium. And then I was like, why though? And started looking into it. And I was like, I feel that this information is outdated. And shocking, I was right. And now we know that people who have kidney disease, like it just checks that box. You have kidney disease, you're at risk for magnesium deficiency. So it's definitely something that we need to be looking at more often for our patients.
Yeah, absolutely. It's one of the minerals safely when I have anyone come in front of me that I go, good chance they're going to be magnesium deficient. So why don't we start off? So magnesium, it's a mineral probably involved in at least 200. That's when I, like you just the other day, graduated from uni. I think it was about 218 that I think I was told. The number's probably tripled since then, but enzymes and pathways that's involved in the body. But can you give everybody a big overview of magnesium, the role, the big functions that it plays in the body that people would probably know, and then we'll get down into what happens in kidney disease, how you would get deficient, foods that are super strong in it, how to test for it, forms of magnesium to use supplement-wise and sort of dosages, and when you maybe wouldn't use it with certain medications, if that's even a thing, and medications that would deplete it. I think they're the big stuff, and you probably have some other amazing things to cover in there that I haven't.
Yeah, so some of the big things magnesium is awesome for in kidney disease. One of the big ones is it really helps with regulating blood sugar levels. So because that's such a contributor to kidney disease, I feel like that's really helpful to know. And a lot of that is stored in the muscle. And so we kind of see this weird, situation happen in kidney disease where um, there's much more of a higher risk for muscle atrophy because of metabolic acidosis and also just kind of general things like people not feeling as great, so they're less active, and other things like that. So you have less muscle mass. That means there's less magnesium able to be stored in and around there, which means you're going to have less support for magnesium helping with that blood sugar control. So a lot of people can notice kind of shifty things happening after a prolonged illness or prolonged period of time where they're um, not able to be as active. And then they're like, wait, I thought my blood sugars were fine. I feel like I'm not doing that much stuff different, but they just have less muscle mass. And
Mm.
magnesium is a part of that. Um, but magnesium in different studies, some of them human studies, some of them animal studies, but for kidneys, just a lower level of magnesium. I think do I have a range? No, it just says that lower levels of magnesium are associated with increased risk of kidney disease, even, excluding other common factors. But not only risk for development, but also the progression of kidney disease. So they found specifically that magnesium helps to lower creatinine levels, lower PTH, and all those other hormones associated with bone management, like FGF23 and clotho. Um, Helps lower blood pressure, um, probably because it's helping to lower clotho, which can help lower blood pressure. Um, but it
Raise
also, go
raise
ahead.
clotho. Sorry, I was going to say raises clotho, decreases
Yeah,
FGF23.
raises clotho. That's what I meant to say.
And
Yeah,
don't
clotho
worry.
is a good thing to have it be higher. And we see that decline with kidney disease for probably lots of reasons. But yeah, it can definitely play a role with that. But there's a lot that we're still learning about clotho, so that's going to be
Yeah.
fun to stay tuned to that. Um, Magnesium also helps with healthy blood vessels, so making it easier for them to respond to pressure changes. So there's lots of fancy names for that, like endothelial function or vasoconstriction or um, things like that. So magnesium helps the vascular muscles of the veins and arteries be more responsive. So again, blood pressure is better controlled. Magnesium is also in the bones, so it really helps with healthier bones, and then also plays a role with the parathyroid hormone, helps increase vitamin D receptor sensitivity, which is kind of funny because magnesium is really essential to help chauffeur vitamin D around in the body. So it's kind of funny that they
Yeah.
have that synergistic relationship that I didn't really
And
realize till later.
yeah, and I'm so glad you flagged that because that's something I only came across maybe the last 12 to 18 months. And
Yeah.
yeah, it's something that people don't think about that if you're vitamin D deficient, and even if you've been taking it, you need to look into the magnesium deficiency because exactly right. Like you might have, and again, it comes down to this testing business too. But yeah, if you don't have enough magnesium, it's not shunting vitamin D inside the lipid membranes. And with
Hmm.
we know in kidney disease, I'm a big believer that chronic long-term vitamin D deficiency causes phosphorus to go up, FGF23 to go up, and clotho to go down. And I believe it's one of, in probably the no other cause mechanism of what happens in chronic kidney disease for EGFR to start to go down. I'm a big believer that is one of the initial mechanisms that will happen 10 years out, and it will be from chronic vitamin D deficiency. And now that you've said it, I'm beginning to think it's vitamin D and magnesium together when you let people get too chronic. So
Yeah, I think it's true. I feel like obviously my brain's thinking so much about hormones, but that was the question I actually asked in the chapter. I was like, this is a chicken or an egg question. Like, does kidney disease cause all these weird, like, bone mineral management issues, or is it this deficiency in vitamin D or magnesium or these other things that are causing these weird hormone issues that then cause the progression of kidney disease? I'm like,
Mm.
I feel like there's a lot of validity to thinking we could intervene earlier and we could have better outcomes. So,
Oh, agree with you. And I mean, I don't need to tell you, you look at the Western diet and then people stressed and not getting enough light and sitting in front. And what the two big things are going to go down in magnesium and vitamin D. They're going to be, and we know, like in clinical practice, them and zinc probably is another one. They're the ones that I see almost 90% of my patients are deficient in those vitamin D, prohormone, and then those two minerals, zinc and magnesium.
well, and I think even without the testing, like when you look at what are the symptoms for vitamin deficiencies, and since we're talking about magnesium today, what are the symptoms of magnesium deficiency? And it's things that we see so common in our patients: muscle cramps, twitching or tremors, depression, heart disease, hypertension, diabetes, low calcium levels, low potassium levels, sodium retention, not having a good appetite, nausea, vomiting, personality changes, mental confusion, which they always want to blame that on uremic toxins, which is totally fair, but it could definitely be mineral stuff. Um,
Mm.
Tachycardia and arrhythmias, also another reason everyone's always like stressing out about calcium and potassium, but we're not thinking, oh, magnesium's a player there. And fatigue and lethargy, those are all symptoms of chronic low magnesium. And it's just like, how many of those symptoms are like, oh, that's just part of kidney disease? But is it? So,
So yeah, totally agree with you there. So thank you for covering that. And I would also say lower stress tolerance is
yes.
magnesium. And actually, I'd be interested to know because I know magnesium is one of the minerals that regulates the delta 6 desaturase enzyme that we spoke about, I think, when we talked about
Mhm.
magnesium and cholesterol and lipids. And I know you're in that at the moment. Did you see any correlation between magnesium and delta 6 and how that's working in the body? Have you
I
not gone
haven't
down?
come across that yet, but I just think like it's such a baseline thing that, if somebody comes to you and they're like, I am super stressed out all the time. I'm super tired. I have a hard time sleeping and it's hard for me to focus. It's hard for me to like all these things. It's like, let's think about what basic building blocks that you need that you're not getting. And let's see how much things improve when you get those things.
Yeah,
Like,
no. All right. So talk to me, unless I've missed something. So testing and reference ranges, because I have a bugbear about the magnesium reference range because it is, they're like, you're low end normal, you're fine. I'm like, you're not fine. So talk to me about
yeah.
magnesium because the bulk of the tests are going to test serum, which I'll let you go into that first before I get on my soapbox about.
Yeah. So the serum, like, bless their hearts, when you finally have someone get a magnesium level tested, it's almost always serum magnesium, which, I mean, this is something we come across all the time with vitamins and minerals. Like, we have to take a look and say, what are we actually looking at? So, because only 1% of magnesium is found in the extracellular space, it's like, well, okay. So if it shows up really, really low, okay, it's probably like horrifyingly low. If it shows up really, really high, yep, it's probably really, really high. But for people that are in the insufficient or even deficient state, the serum magnesium is not really going to be effective for us. So a lot of times people are saying, well, we should be looking at red blood cell magnesium because that's also what tells us like how much magnesium is actually getting into the cell. So I do really like seeing that, but the thing is that there's going to be some degree of time delay of what that's showing us. What is that, like 4 to 6 months? The past 4 to 6 months is what that shows us.
Yes, it's red blood cell turns over every 3 months. So you're looking at, yeah, three, 4 plus because you've got to get it
Yeah.
into the, it's got to replenish the cell through the bone marrow and well, that pathway
Yeah.
goes. So 4 is probably quite accurate.
Yeah, so that's kind of what was sticking in my head was 4 months. And
Mm.
so it's like if the person has been like if things have been fairly consistent for them for the past 4 months, then you're probably getting an accurate thing. But I feel like life is so up and down that my stress levels, my eating patterns, my sleep schedule, all those things are not going to be consistent enough. And so I think with any vitamin or mineral, you're going to have multiple data points. And so
Mm.
you want to find the best test you can, which I feel like red blood cell is going to be your best option. The range, though, I feel like the serum levels of what is or isn't okay are super debatable. One study that I saw said between 1.9 and 2.1 are that is the range that says if your magnesium is here, this is associated with less mortality if you have kidney disease. But I feel like there's a big range between optimal and you have less risk of dying.
Yeah. And I think
So,
we must use a different reference range Australia because I think we're like 0.68 to 1 point something. And I can't
oh yeah,
remember.
mine's milligrams per deciliter is what
Yeah,
we're looking
mine
at.
might be, I can't remember. I'd have to go and look up what the actual unit is. But it's, I get so many people come back at 0.7 and I'm like,
Mm,
well, we're normal. And again, that's generally not, that's, and I'm looking, sorry, I'm talking serum. So I'm like,
yeah.
okay. And then I'm like, and we know that most of the magnesium's not going to be sitting there. So if you're low and normal there, then your bones and where it's actually sitting into skeletal and bone tissue, I'm like, so it's so hard, isn't it? I think with magnesium, I don't know if you agree with this. It really is. I will run a red cell magnesium, but bulk of it is I'm coming off symptoms.
Well, that's what I think. And this isn't this like the big problem that so many of our patients feel frustrated with is they have all these symptoms and they're not able to like live their life. And the doctor runs tests and says, well, these test results say that you're fine. And then it's
Yeah.
just like, okay, thanks for nothing. And so that's where you do have to be a clinician and say, okay, one of the data points is going to be what is my best option for testing the levels in the blood, but I know that there's, you know, it's limited. We don't have the Star Trek scanner, much to my dismay. So, um we have to go off of symptoms. And then as a dietitian, I'm looking at what are they eating. And a lot of my clients are super awesome, willing to go through the arduous task of logging their foods into, an electronic food record, like Chronometer or Chronometer, however you say it. And so I can kind of get, an idea of what their intake is like. But then I think you also have to look at does this person have digestive issues that could mean that they're not absorbing things as well? Or do they have other risk factors that would increase their magnesium need or risk for deficiency? And so I think that that's what makes a good clinician is they're looking and at all those different types of data points and then coming around saying, well, I think my patient needs this much, but based on this data, it looks like they're getting this much. So how are we going to make up the difference? Or what kind of issues do we need to resolve so that they can absorb more or get more or have less need or whatever?
Yeah, it's such a great point. And you're right. It is an eternal frustration of patients that, exactly that people they get dismissed because they're like, there's nothing wrong. And you're like, there is something wrong. And we might look at it and go, well, you are deficient, but the tests, you've got to be nuanced in how you look at it. So talk to me then about, and you can do in whatever order you want, supplementing and forms and also foods. Is magnesium something that if you saw it with kidney disease, are you going, okay, we can just do it through the diet, they can log it through the chronometer, and then I can see that way? Or are you going straight to a supplement? How do you do that in your clinical practice?
So I do like to take a look at what my clients are eating. And I like to get kind of an average over like at least a week or something, or maybe like 6 days over 2 weeks, something like that. Just because I know people don't eat the same exact every day, and I don't expect people to micromanage stuff that much. So I look at that and I say, okay, based on what your current eating pattern is, you're meeting, if they're only meeting like 40% of their needs, and if it's easy for us to say, well, hey, you love, these higher magnesium foods, then, and that's easy to add in, then I like to do that. However, if someone really is showing a lot of signs of deficiency, I'm like, let's just get you supplemented. And depending on, like, if they're having lots of gut issues and stuff, I'm actually probably going to recommend an IV therapy for them
Mm.
for vitamins and minerals, just because if the gut isn't working, you're going to have to take the time to heal the gut. They're going to get replenished, but it's going to be a lot slower. And if their symptoms are already really bad, like, it's just like, let's just, have some mercy. We have another avenue where you can get IV B vitamins and magnesium and stuff. And lots of offices here, at least in the US, like functional doctors' offices, they are drawing those labs and doing those consults so that it's a lot easier for people to get access to that. I don't know how much insurance will cover for it, but I just feel like if someone has a lot of barriers for them to be able to meet that need, or their need is really high, I would go IV. But then if that's not an option, or maybe it's not maybe that severe, I would do a supplement just to kind of help them get back on their feet more quickly. And then once some of the symptoms are starting to resolve, then we can take a look and see what can we adjust with your diet, then maybe we can move off this supplement, because I do think it's ideal if you can get it from food, or like, hey, maybe you just need to take the supplement like 3 days a week just to kind of top things off or whatever.
Yeah,
um,
perfect. And do you have a favorite, do you have a go-to sort of form of magnesium, or there are, like, I know I use a couple of different forms, but in kidney disease, is there one that you prefer?
Um, for a lot, I like to use magnesium citrate, because that is going to help alkaline things. Um, but the most common one, at least in the US, that is just like everywhere, is magnesium oxide. And I kind of hate it,
Yeah.
because a lot of people are taking magnesium actually when they come to me because they have constipation, and everyone hears how magnesium is great for constipation, and they're using magnesium oxide. But correct me if I'm wrong, I feel like the reason why magnesium oxide works so well for constipation is because it's so not absorbable and it causes diarrhea. And so I'm like, it sounds like you're doing the right thing, but actually, no.
That's 100% right. You don't really, it's a terrible form of magnesium. It doesn't get into the red cells. And you're right, it just causes basically relaxation of the muscles inside the gut where it hits. And so
Yeah. And then it's not giving you the magnesium. And then if the transit time is so quick, like you're not going to absorb the rest of your nutrients. So I just really don't like that one. Um, and I think that that's just going to exacerbate whatever gut issues and other nutrient deficiencies people have. So it doesn't matter. Like, there's a lot of research that's specific for certain types of magnesium for certain types of things. But I feel like the reason to take magnesium oxide would be because you just simply want diarrhea and you want fewer nutrients. That's the advertisement for magnesium oxide.
No, I totally agree with you. And yeah, magnesium citrate's my go-to. I like magnesium threonate for brain health. If people are a bit
Hmm.
brain foggy, sometimes we've got some great formulas in Australia where you can get a mix of them. And then
Hmm.
magnesium biglycinate's the one like Metagenics and all those guys use. I'm not a massive fan of that one. But yeah, citrate and glycinate is the other
Yep,
one that does seem to be very well absorbed if you want to
yes.
more for muscular. I think that's really your muscular skeletal replenishment sort of one. But no, yeah, but we've got somewhere you can get all three in there and get them in a good mixture. I tend spartate, magnesium spartate was the one back in the early 2000s and 90s that everyone was using, which does hit the mitochondria a bit more. And magnesium malate, that actually,
That's the
sorry,
other one I was thinking. Hmm.
yeah, magnesium malate goes into the mitochondria. So great if people are super fatigued. But it's interesting in Australia that the form, it's how things change. I can't see magnesium malate in really anything anymore. everyone's moved to glycinate. It'd be the biggest one we use in Australia, citrates as well. And then lots of people using the threonate for deep sleeping and brain health and those sort of things. So they're the big three popular ones that we see here in Australia, at least.
Yeah, I definitely see, like, again, magnesium oxide is just like you could pick it up off the ground basically. But a lot of the other supplements, it is common enough to find a combination of like magnesium, citrate, malate, like things like that. You can find combinations of them here. And then, yeah, the glycinate is definitely, I feel like, the more popular one for the absorbable or bioavailability there.
Yeah,
So.
yeah. Okay. So foods, what are your go-to foods that are nice and high in magnesium that if people are listening and they're not quite sure, they're like, I don't know if I want to supplement, what would you tell people to increase in their diet to get magnesium?
So, especially if you're kind of on a lower protein diet, you're looking for more plant sources. If you're adding things in, so you're not using up your protein budget, most animal foods are going to have good sources of minerals that are bioavailable. So, if you have room in your food budget to add a little bit more animal protein, that's probably going to help. But if you're like, well, my protein budget is already stretched to the limit, um, plant sources that are higher in magnesium are things like spinach and quinoa and hemp seeds. Hemp seeds, I was actually quite surprised with. Um, they are pretty high. And then also buckwheat. Those are like the four highest ones that I found. But we have to remember any minerals from plants, their bioavailability of minerals are going to be not very high. Um, but you can also eat more of the plant food as well, and have your protein budget go further. So kind of just depends, but I do personally really like the hemp seeds because they're really, really versatile and they don't usually tend to change the flavor of things a lot. So that's one of the things that I often recommend for my clients. To add to smoothies and oatmeal and salads and soups and all that kind of stuff, to help add their magnesium intake. So, how about you? What's your favorites?
Yeah, no, I didn't realize that hemp seeds were so high. Generally, that's the, like you say, it's the animal protein where you're going to get most bioavailability. And then, it was always the nuts. I think almonds are quite high. Maybe walnuts is another one of the high ones that people can add, or just a tablespoon of nut butter a day and things like that. But apart from that, yeah, no, exactly what you've said. Are there any pharmaceutical medications that people might commonly be on in kidney disease that you would see deplete magnesium?
Yes. So, loop and thiazide diuretics, they're magnesium wasting. Um, PPIs, anything
Mm.
that lowers the stomach acid is just going to lower your absorption of any kind of mineral, not just magnesium. Um, some stool softeners and laxatives. There's some magnesium-based laxatives, but others that aren't, and they can lower magnesium. Um, excuse me, calcimimetics, immunosuppressants, specifically cyclosporine, tacrolimus, and some chemotherapy medications, cisplatin. Some of these I don't really know how to say, so just, round it up with that. Um, yeah. So.
Cool. Okay, and then my last question for you with magnesium, and then anything that I've forgotten, is there any time, actually, I'll go to this, people on dialysis, because that's the big thing, right? And you sort of touched on it right in the beginning, that if you're on dialysis, a lot of patients still that, or clients that come and see me are still being told that they cannot go on magnesium. That's still the old school thing going around. So if someone's listening to this and they're like, well, I'm on dialysis and my nephrologist has said I can't have magnesium, what would you say to that?
So I think this is where we can just go about it like talk with the dietitian about it and say, hey, I have XYZ symptoms. I'm wondering about my magnesium levels. And the dietitian can assess the diet and say, oh, yeah, you're getting 200 milligrams of magnesium. That's really not enough. The other thing to remember is that dialysis sessions can actually reduce serum magnesium levels by like 50% after one treatment. Like dialysis does remove magnesium, so I feel like that's another box to check. And so I think if a person is willing to track their food and say, this is how much magnesium I'm eating, and it's below that, really sorry RDA that has been established, then I don't see any reason why they couldn't supplement to make up that difference. Like that's super like low risk. But I think, if you want to do some additional testing and see what your red blood cell levels look like, and even your serum levels, because if someone really is low, like if it really is really low, it will show up in the serum, even though it's not, super awesome. So
Yes.
but I think, also looking at, what those symptoms are. So it's just being like logical about it. It's like, hey, I am not eating enough of this. I have these symptoms. Um, people who have kidney disease, they lose more magnesium, especially like with proteinuria. Like you're just losing all kinds of things. And if you have other things like low writing potassium, because you need to have magnesium to help absorb your potassium, that's like another thing. And also, if you have bone management issues, getting your magnesium levels up, it's going to help your vitamin D levels because you need magnesium to move vitamin D. You need it to activate vitamin D and then deactivate the vitamin D when it gets too high. So I feel like there's lots of reasons why it's like this is a low risk intervention that could have lots of positive benefits for somebody.
I totally agree. Is there anything we haven't covered about the magnesium, amazing magnesium, I meant to say there, that you want to add before we wrap up magnesium?
I think we covered all the high points that I kind of jotted down before. So, oh, the other thing that helps with magnesium is vitamin B6 helps transport magnesium into the cells. So again, like if you get a serum level and a red blood cell level done and you're seeing a discrepancy there, you could consider what the B6 levels are looking like. Especially if the levels look like kind of okay, but you're still having lots of symptoms, then B6 could be one of the missing pieces.
Very good. Thanks for adding that one in. That's good. Okay, Lindsey. Well, that was amazing as always. So thank you. If anyone wants to work with Lindsey, I'll put in her link below, but it's kidneynutritionalinstitute.org. She is one of our practitioners there. And then if you have any questions, you can pop them in the chat below and I will make sure I answer them. Doorbell going, apologies. So if you want to know more about what we do, head to www.kidneycoach.com. You can also find us on Facebook. Make sure you hit subscribe and like. That way you'll get updated anytime we put up new content. Lindsey and I will be back in 2025 with more minerals to come. I'm thinking maybe selenium next time, Lindsey. What do you think?
Love selenium.
Yeah, it's one that not people don't talk enough about. So I'm going to put that, I'm flagging that for January for 2025.
Sounds good.
Thank you for being part of our community, Lindsey. I know how busy you are with writing this chapter. So again, thank you for taking time out to talk to me and our community about all things magnesium. And we will see you everyone in 2025. Bye.